Hello, everyone, and thank you so much for joining us again on the Empowered Patient podcast. Today, I am very excited to invite Dr. Sheba Roy. Dr. Roy is one of only about 75 board certified fellows in the American Board of Naturopathic Oncology. She's practicing in the United States and Canada. She specializes in supportive care for cancer patients and integrating natural therapies safely and effectively alongside standard treatments like chemotherapy, radiation, and surgery. Her focus is on co managing treatment side effects, preventing dose limiting complications, and improving surgical outcomes using evidence informed natural approaches. Dr. Roy also works with cancer survivors to reduce the risk of recurrence and prevent long term side effects that can impact both quality and length of life. Her approach is all about optimizing each phase of care and supporting the whole person and healing. I can't wait for you all to meet Dr. Sheba Roy. She is helping to redefine what is meant to truly support cancer patients, both before, during, and after treatment. Welcome.
Thank you. So I
Hope I
heard we're
did
going
you
to do
some
first
justice.
names. So
Yes.
you did. Thank you, Tiffany. Um, that was a beautiful introduction, and that is, exactly what I do. I am what's called a FABNO, a Fellow of the American Board of Naturopathic Oncology, and I
Hmm.
think that that can be a little confusing because there is something called Integrative Oncology.
Yes.
They're kind of one and the same. Um, it's just, I think what varies is board certification and licensing and all those kinds of things, which
Hmm.
I'm sure we'll get into.
Sure. So tell me a little bit about what your everyday type of thing looks like. How do you structure your day when you're seeing your patients?
Okay. So, probably much like oncology, we see patients back to back. The difference is those are hour and a half consults.
Wow.
So yeah, so we get a chance to really meet not just the patient, but their entire family. So they usually come in because they're referred by oncology.
Hmm.
Um, Sometimes they're with us because of they're their word of mouth, but we like to get people when they're first diagnosed, and
Hmm.
we like to get a sense of who they are and what their motivation is to be here. I try to reframe this journey as not so much about disease, but about um, figuring out why you're here and who do you love and who loves you in return and what can you let go of? What conversations have you had not had with yourself about the meaning of your life? And so it's really
Wow.
important to capture that in the first visit and get a sense of what their through line is, because that's what allows us to return over and over again to their meaning and their will to be here when we do face the challenges, whether it's tolerance, whether it's recurrence, whether it's something as basic as scan anxiety during surveillance.
Mhm, mhm. Wow. Those are
So,
really deep topics that you get into just in the first consultation. That's amazing,
yeah,
really.
yeah, it is. I'm in a small pond. I'm in Michigan, and
Mhm,
I have a practice called Associates of Integrative Medicine.
mhm,
And we partner with a bunch of other supportive care providers. Uh, but I think because I'm in a small pond and I have a strong reputation here,
mhm.
people do come in wanting that relationship and wanting that kind of care. And they have already, as you know, gotten on the internet, read a bunch of
Right,
things, and
right.
they have a story already or a sense of who we are.
Mhm,
And I think that helps actually. And I think oncology is somewhat as a deficit because doctors are slow to get to the place, and not so much you, but slow to get to the place where personality and who they are as a person matters as much to patients now
mhm.
as the care they're providing. So when patients are looking for an oncologist, they really don't have a sense of who that person is.
Mhm.
And there's a lot of fear and a lot of, as you know, a lot of fear, a lot of anxiety coming into a new office. So we do a lot to levy that. We have a space that's really geared towards making them feel safe. We have meditation music on. We don't keep any literature or magazines in the office that talk about body image or disease or
Hmm.
even the word cancer. We ask them at the outset, are they comfortable with the word cancer?
Mhm.
And we don't use it if they're not comfortable.
Mhm.
Um, and that first visit, we spend a lot of time navigating. So we go over how were they diagnosed, what their ethnic background is, what their marriage situation is or partnership situation is, what
Mhm.
their family life looks like, um, what their goals are, what their fears are, and as I said, motivation to live. And then, of course, the typical doctor stuff.
Mhm.
Um, but it gives us a big map, and we also pull before they come in, as you probably do as well, their imaging, the pathology report, and we spend the last portion of the visit with a whiteboard mapping out how did this happen, how cancer works, and what are the potential drivers that we're going to focus on. What are the drugs or the treatments that have been prescribed? How do those typically work?
Wow.
And what are we going to do to support them through it? And I think part of that is because we're private pay, we have that kind of time
Mhm.
to really give them a visual map, and that's recorded for them.
Wow.
So I really give them a visual map where they can navigate their diagnosis better.
That is so comprehensive and thorough. I have chills about how wonderful that is. I mean, honestly,
Oh,
every oncologist should have a partner with somebody like you. I mean, how do we expand what you're doing? Are you only seeing you said you're only seeing patients in Michigan. How can I get my patients to see you?
so I do see patients from all over the country and sometimes overseas.
Mhm.
I'm just saying in Michigan, it's a small pond. There's 5 or 6 large cancer centers, and
Mhm.
everybody knows everybody. So it's a little
Mhm.
bit of a different environment.
Sure.
Um, but anybody can see us. I think the difference with being in Michigan is like like we were talking about before we started, I could pick up the phone and text the head of gyn-onc at Carmanos.
Right.
I can help patients navigate better. I know who's going to be a good fit.
Mhm.
Who are the best pelvic floor therapists, who's going to have an office where maybe it's only women are seen there,
Right.
who's going to have um, who's going to have the latest access to trials and what trials are going on at each institution. I think it just gives them, what institutions are struggling with with instability with staffing, those kinds of things. So
Hmm.
it
Mhm.
helps the patient to really make the right choices for themselves
Right.
about where they are and feel truly empowered. Like I love that you talk about empowerment with patients. I think for on the other side of this, for us,
Mhm.
the words are so rote for us. Like we understand this language. It feel like even the word
Mhm.
biopsy or pathology or,
Mhm.
antineoplastic, those words to us are ABCs. To the patient, it really is like when we were in our first year of medical school and you walked into anatomy, it really is like Greek to them.
Yeah.
And so they not only have been told that they're facing the possibility of dying well or living well, but they're at that crossroads without the language to navigate that system. And I don't think as doctors we have the time, or even many of us are not skilled in breaking things down in a way that makes it accessible to them. And a
Yeah.
lot of patients want to know why. And I think if you really understand carcinogenesis and you really understand the hallmarks, the seminal papers, how cancer works, it's fairly straightforward to kind of map that out in a way that gives them tangible things to hold on to. For example, you inherited genetic markers that put you at risk. And what that means
Mhm.
is when your parents came together, the cards got shuffled, these were the cards that you dealt. It's not something that you did.
Right.
However, these are the things that drive cell growth, and this is how we can manage that increased rate of cell growth
Mhm.
while also supporting you with this drug treatment.
Right. Very interesting. So, when I first reached out to you, I actually had thought that you were primarily somebody that helped manage side effects and symptoms of the cancer itself. But it's
Mhm.
amazing the depth of and comprehensive value that you're adding to this whole process. I mean, it sounds you're interpreting for the patient, you're explaining it to them, you have the time to sit down and really get to know them as a person. I mean, that's really remarkable and very, very special. Can you speak to how you also help with symptoms and side effects?
Yeah. So let's say we're talking about an early stage breast cancer patient
Hmm.
who is going to be getting a lumpectomy, 4 cycles of ACT. So for people listening to us, those are that's an acronym or for 3 drugs,
Hmm.
and then they're going to get radiation. So for let's start with a lumpectomy. So that is a type of surgery where um, the doctor is removing the the tumor, and
Okay.
our job is to prepare the patient for the surgery, make sure that they have a pre-surgical protocol, so things like increasing protein, increasing antioxidants, knowing not to take supplements or natural therapies before treatment, knowing which things to take to optimize gut function, reduce the risk of infection, which is very low with a lumpectomy. It's not a great
Right.
example. But either way, the patient doesn't know that. So they feel that,
Hmm.
this is a surgery, and it is. And they want to understand how to approach that in the best way possible. We really talk about aesthetics. And as you know, with breast conservation
Hmm.
surgery, patients usually do have great looking breasts after a lumpectomy, but sometimes that's not the case.
Hmm.
And so talking about preparing for what that can look like and what we can do post surgically. On the East and West Coast, in plastics practices, they use things like arnica, which is sort of an energetic medicine for bruising and swelling. They use
Hmm.
bromelain, which is from pineapple, and it reduces the risk of scarring, helps to improve the aesthetic outcomes. They use, like a surgically formulated multivitamin, those kinds of things. And we use those as well because
Wow.
aesthetics are so important to our patients post-surgically. So, um, and then talking about, what does that pathology report mean? What do all those words mean?
Right.
So, um, so there aren't really side effects from a lumpectomy that a patient would be worried about, but sometimes there's some nerve pain, like
Hmm.
zinging pain that the
Sure.
patient might have. Sometimes there's like a physical, protrusion where maybe they had um, uh, uh, a clip or something else. Maybe there's an expander placed, if they had more than just a lumpectomy. So our
Right.
job afterwards is also to lower risk of infection and make sure their body is tolerating whatever was placed.
Hmm.
But we become more important with something like drug treatment. So with
Sure.
chemotherapy, like Adriamycin, as you know, the risks are primarily heart disease, short and long term. And less well known, there's a risk of kidney disease associated with Adriamycin. CoQ10, for example, used in conjunction with Adriamycin, helps to mitigate those short term effects. A lot of patients don't know that the long term effects can persist even 10 to 15 years out or show up later in life. And
Hmm.
they may be coming into treatment with risk factors for heart disease. So we're also evaluating for metabolic health. We're evaluating, meaning how their body uses fat and sugar. We're
Hmm.
evaluating lipid status, family
Hmm.
history of heart disease. We're
Hmm.
looking at things like lipoprotein A and apoprotein B, which tell us about how sticky the blood vessel wall is and how prone that person is to picking up fat and it narrowing that blood vessel wall.
Hmm.
We look at how their body manages sugar, because as you know, if a person is prone to struggling with how they manage sugar, it increases the risk of heart disease. We look at weight, exercise, we look at obstacles to exercise. So when we're talking about Adriamycin, we're
Hmm.
talking about actually that whole person approaching a higher risk of heart disease. And patients hear all sorts of things on the internet that scare them. Things like
Right.
the red devil,
Devil.
or this person's
Right.
poisoning me, or chemotherapy is poison and I can take something else instead. And or chemotherapy doesn't work, which is not necessarily that far off. It has, at that level, low efficacy rates, where surgery is curative in that case. So it's really about helping them to understand Adriamycin and have a relationship with the drug. So Adriamycin comes from a strep bacteria that was discovered in this red soil outside of this 13th century castle in Italy. And it's part of the natural world. This little tiny critter has the potential to save lives, and it's part of God's green earth. Whatever their faith system is, we work with that. Um,
Right.
and making sure that once they're in survivorship, which this patient is an early stage breast cancer patient, they will
Sure.
be in survivorship or
Right.
thrivership, making sure that they understand that how we're preventing the side effects now will actually also lower their risk later, because we know that higher BMI, metabolic issues, and exercise intolerance will increase their risk
Hmm.
of recurrence. And it also, we also know that hormonal blockers, so like anastrozole, tamoxifen, that those can change the way your body uses fat and sugar.
Hmm.
So it's really important to optimize that at the outset. So there's so many pieces to managing the side effects of Adriamycin.
Of
It's more
course.
like, how do I take this drug and still live my best life?
Right. So let me ask you a question, because a lot of my patients are breast cancer patients, and some of the most common things that we're talking about right now, um, and is being talked about a lot on social media, for example, is this onset of menopause and all of the menopausal symptoms that come along with patients that have ER positive breast cancer and need to be put into menopause and or take an estrogen receptor blocker. So would you talk about some of the things that you utilize to help your patients with the menopause symptoms?
Yeah, sure. So again, patients are coming to us often over-informed in some ways and under-informed in others, because they're using the internet, and they first want to know, do they need this drug therapy? They thought they were done. And so it's really important to get compliance. And part of how we get that compliance is going back to the motivations. Why are we here? What does this mean for me, this
Mhm.
journey? And really thinking about, what does it mean to be a woman? A lot of times people lose. There's a great book by Judith Viors called Necessary Losses. So when you're going through cancer treatment, sometimes you lose your libido, your vaginal tone or vaginal lubrication, your hair, your eyebrows, your eyelashes, your sense of self, your finances. There's just a lot of losses. So when
Sure.
they get to the point where they now have to take a medication to block estrogen, it feels like another massive loss when they thought they were done. So I think being sensitive to that is
Mhm.
almost as important as managing the side effects. But for us, we use things, so it's not a one size fit all. Just to
Right.
say, we
Of
do
course. Sure.
comprehensive testing to really look at the patient's metabolic profile, hormonal profile, how they manage stress, risk predictors for heart disease before we
Mhm.
design treatment. But let's say this patient is, I'm going to give you kind of a hit list. This
Sure.
patient's at risk for joint pain, mood lability, meaning their mood may go up and
Right.
down,
Sure.
um, hot flashes, sleep issues,
Mhm.
and let's say metabolic changes. So w- without being this is going to be overly simplistic, but we would use fish oil, magnesium, B vitamins.
Hmm.
Black cohosh has excellent data. I think there's a lot of confusion about that, but about phytoestrogens. So there
Hmm.
are plants that are estrogen modulators, meaning they shift. Estrogen is an umbrella term, as you know, for 16 different or so chemicals. And some of these botanicals will shift towards the more protective forms of estrogen and also manage side effects. We work
So
really
you're talking
hard
about like
on.
E3, or you're talking more about on the receptor side, like estrogen receptor alpha and estrogen receptor beta? Is that what you're talking about?
Yeah, I am. I'm talking about more of the on the receptor side.
Yeah. Okay.
So I think the confusion for oncologists sometimes is, are phytoestrogens appropriate in this population? I think it's a
Hmm.
misnomer. They're not estrogenic per se, and they don't increase risk. And even now we know that very low dose estriol
Hmm.
used topically can be helpful and not increase risk. At least most of us think that.
Yeah,
Um,
I'm in.
so speaking of, we work really hard on vaginal dryness and
Sure.
intimacy, recovering intimacy. Often intimacy is lost on this
Hmm.
journey. So recovering intimacy, we use vaginal moisturizers like Replens and Reverie, but we
Hmm.
also use, there's a really good study called the EVU study that looked at just using different oils and vitamin E for
Hmm.
vaginal dryness. We use pelvic floor therapy. We talk about sex education. We
Hmm.
talk about foreplay. We talk about lubricants using non glycerin, um, non petroleum based lubricants. We talk about breath work, and we usually know the family, so we also are talking to the partner as well.
Hmm.
Um, we find that our patients do really well. Curiously, if they have a history of alcohol abuse
Hmm.
or a history of depression in their family, they don't do well, even with supportive care.
Really?
But it's very, yeah, it's rare that I have any patients on estrogen, uh, uh, estrogen therapy, and I don't mean estrogen. I don't mean
I know.
supplementing
I know.
estrogen. I know you know. I'm talking. I don't
No,
know
it's a
if our
misnomer.
audience are doctors or patients. Yeah,
Oncologists call hormone therapy, which is actually anti-hormone therapy, as
right,
opposed to
right,
hormone replacement therapy, which is,
right,
giving back the hormones. So it's
right,
exactly a misnomer.
right. So most of our patients don't have side effects. That's what we're there for. Is if our
Great.
patients have side effects, we've either failed or they have. Sometimes they do have some sort of um, genetic reason why they just don't tolerate. Like I have patients who have severe reactions, for example, to tamoxifen, and they simply can't take it, and we have no idea why. Usually,
Interesting.
those patients are Ashkenazi Jewish from a very specific part of the world.
And when you say they can't tolerate it, meaning that they get just such severe forms of the side effects of tamoxifen, such as hot flashes, mood changes.
No, I mean more of a of an allergy type picture, like more of a
Really?
reaction to the drug. Yeah. Um, for side effects,
I don't
like
know that I've ever seen that, to be honest.
yeah, I've seen it twice.
Okay.
And I've been in practice for 17 years, so it's not a lot of people, but I
Right.
have seen it before. I don't have patients who have to discontinue hormonal therapy because of side effects. I haven't had that happen yet.
That's amazing. Then you're
Yeah.
doing a great job, a really good job. That is way above the average curve for sure.
But imagine we're treating Tiffany like all of the other pieces of their
Mhm.
metabolic health, their
Mhm.
mood, their
Mhm.
sleep,
Right.
their nutrition, their exercise. So there obviously are, other factors that are contributing to
Sure.
why when we go through menopause, we have these effects than just estrogen withdrawal. You know
Yeah.
what I mean? It's not that simple,
I
actually.
love the holistic approach. I really do. So, may I
Yeah.
ask you, when you say you do a comprehensive evaluation, what tests are you ordering? You're not ordering the usual, comp panel, which is electrolytes and LFT, liver function tests. You're must be ordering. functional medicine type tests, right? Is that what you're
So so because it's expensive, very
Mhm.
expensive to see someone like me, we try to draw everything through insurance. So
Mm,
there are functional medicine tests, which is Tiffany's talking about things like a Dutch panel, which
right,
like outlines hormones in detail, or a microbiome test that
right,
looks at how your gut is managing inflammation or dysbiosis, which means like an imbalance of your gut function. Those kinds of tests we will do if we're not successful at the outset. What I mean by comprehensive is we're looking at more than just their bone marrow, a CBC diff, and a comp panel. We're looking at a thyroid panel. We're looking at iron, magnesium, B12, B6, CoQ10. We're looking at risk predictors for heart disease like HSCRP, lipoprotein A, ApoB, but everything we're drawing is under their insurance
right,
to
okay,
start with, because we don't want patients to get in the weeds. Like you really can figure everything out in the beginning using standard of care guidelines and standard of care testing.
right,
We uh, it really should be the primary care, to be honest, who's skilled in seeing the cancer patient alongside the oncologist.
mhm, mhm,
Problem is primary care is undereducated in cancer treatment,
mhm,
and when a patient is diagnosed with cancer, as you know, they often lose their primary care because 'cause they're seeing so many specialists
mhm,
that the primary care becomes less important,
right.
um, and they
Almost
work
marginalized,
closer.
I think.
Yes, yes, exactly, and
Mhm,
that speaks to that point about collaboration.
right.
It's like I'm an excellent primary care doctor, but who is, really educated in just cancer patients. Does that make sense?
Absolutely. So, can I ask you, just because that it's so fascinating that the niche that you're in and how needed and important it is, what was your pathway to getting to where you are now? How did you develop this? Where did you learn the skills that you have? Has it been, just on the job education, or was this how you trained?
So I'll give you a little personal background,
Okay.
which is that my father is from West Bengal. My mother's from Africa, and I spent a lot of time when I was younger
Hmm.
working with populations that were hospice populations, basically, overseas. And I did that work for years.
Right.
And I always knew I wanted to be a doctor. My dad was an old doc, and he owned several large full facility clinics in the Detroit area. So he started me out really young. I started at 8 years old as a janitor. He had
Wow.
read all these books about great Americans like Lee Iacocca, and you may not know who that is, but these are motor industry execs.
Okay.
And they had all started from the bottom up. So he started me out cleaning toilets and putting up the no smoking signs, and I loved my job. And I always worked for him, and I worked my way up to the front desk by the time I was in high school. And so when I went on to college, uh, um, I took a different path initially and then decided to do pre med. And I was on a very traditional path. I was pre med at Harvard, and I went to Hopkins for master's in health policy and was going to continue on to medical school there. But I was working after school and on the weekends as the educational director for the Crohn's and Colitis Foundation in
Hmm.
Maryland,
Okay.
where I was in school. And I was really surprised. I was running support groups for that's that's for patients who have inflammatory bowel disease, which
Right.
shares some keynotes with cancer, but basically
Hmm.
these are patients who are taking a lot of drug cocktails at times, high doses of steroids, and experience a lot of physical discomfort. And in running those support groups, I was really shocked to hear about the patient experience. And every day to sit there and listen to what people went through when they left the doctor's office. Because I don't think as a doctor I had ever really I wasn't a doctor, but as being on the other side of it, I don't think I had ever really heard what it's like for people when they go home. How do you manage all these prescriptions? You know, what are the logistics? Like, just the scheduling pieces, all the nightmares associated with a diagnosis. Um, and they kept asking, "Isn't there anything different? Isn't there anything natural?" So, I was young and very naive, and I thought there must be. So I chose to pursue a doctorate in natural medicine in Washington State at Bastyr, and I did a combined degree. First 4 years were conventional, and the last two were evidence-based and complementary and alternative medicine.
Hmm.
And then because of my connections and my opportunities, I was able to do a residency in internal medicine in Detroit, and then fellowship at Cancer Treatment Centers of America in Eastern Regional Center in Philadelphia.
Oh,
And
wow.
that's where fellowship is where you become an expert in whatever you're doing.
Hmm.
So I think my path was fairly conventional. I just happened to intersect patients at a time in my life where my heart was really open to doing anything. Now, had I not been so naive, probably would have done my MD at Hopkins and my MD in Washington State and be doing something bigger, but I didn't.
Bigger.
Well,
Did you say
I think
bigger? I think what you're doing is so applaudable. It's just amazing. I think you
thank
have.
you. I mean that I think that we do need people like you, or people who speak this language at upper levels of public institutions. Like, I do think the system has to change.
I
Um,
agree,
and
100%.
the system needs to integrate better. Like, I love this conversation because I think oncology is really slow to understand the value of supportive care, and they think of it as a nurse's job. And nurses are great, they're awesome. They're also overworked, understaffed, and they
Yeah,
aren't really skilled. They aren't a doctor, they aren't skilled in what we're doing, and they
right,
don't have an hour and a half with a patient.
right. Well, I'm from the East Coast. I came from Memorial Sloan Kettering, and actually, in the past few years, they have developed a phenomenal supportive care system, which is
Mhm.
fueled by physicians, nurse practitioners, and then it's a traditional, sort of setting. They do a lot of telemedicine, and the problem is that there are not enough of them. If every
Yeah,
single one of the patients I saw in a clinic day needed to see supportive medicine, they would wait 3 years to get in to see them. And so,
I don't think
most of the time
yeah.
they were getting our really sick, really difficult to manage patients. And oftentimes they'd be getting them right before they were probably ready to go on hospice. So, it
Yeah.
was, and I don't think that probably is the best use of the supportive medicine. I like what you're doing, where it's integrated from the very beginning, and you're part
I
of the
agree, I
story.
agree. I think it's such a good point. I think oncology here is really good about referring to us, but they often don't think of it until the patient is really suffering.
Yep.
And they've exhausted their options, and that is really hard when you get those patients. Half our patients do come to us very sick, half our patients come to us stage 4. So
Yeah.
it is it is a very different picture then, but it's still, still all of those principles apply.
Yeah.
They're a whole person, and there's a
Right.
lot of factors that are contributing to how they manage pain, how they tolerate pain medication, whether they even understand how to take pain medication, all of those pieces.
Yeah. It's wonderful that we have these options, and I'm really looking forward to be able to transfer some of my patients and share with you to, help educate, especially in the space that I'm in right now. I'm doing sort of concierge, second opinion cancer treatments, right? So I don't actually prescribe any medication, but I'm basically filling in the spaces the same way that you are. And so, when a
Mhm.
patient comes to me now, I spend an hour and a half with them reviewing everything that they've gone through so far and making sure that I explain it to them on a level that they understand and can actually translate it back to me. Um,
Mhm.
and the book that I have written that's coming out, hopefully very soon, is also, for that purpose, to help really kind of explain the language, like you're saying. And I really think that this is the way that patients need to be handled, especially as we get more educated and more technical, but the lay population isn't catching up. We have to help fill that gap between them, between the language we speak and the testing we know of as secondary, like you were talking about, as second nature to us. Patients are just they don't know what it is. They don't know what's going on. Overwhelming.
Yeah, and I agree, and I think what you're doing is really important because you're basically taking the time to give them a second opinion that is far more nuanced and far more comprehensive, and you have the time to explain things that their primary oncologist may not.
Yeah.
But
Yeah.
I think one of the things that's really, really important to talk about in this space is there's a lot of misinformation out there
Mhm.
that cancer patients do not need and should not take cancer treatment. And that is a far bigger problem than I think oncology is aware of. Oncology, at least here, is seeing 40 to 60 patients a day, and I
Per
mean, in
doctor?
some ways, can't,
Yeah.
yeah, I think in some ways,
How?
can't, yeah, it's insane. And I think in some ways, cancer is an epidemic, at least in my part of the world.
Mhm.
Um, it's very, very common. And we're seeing younger and younger people, getting diagnosed with colorectal in particular, but even
Yeah.
breast and prostate. And I think as that happens, we're also seeing a patient population that's driving a need to avail themselves of natural therapies safely. The NIH estimates 86% of patients diagnosed with cancer want to take and are taking natural therapies. And the
Mhm.
problem is that
And
if their
sometimes not telling
oncologist
the
isn't
doctor about it.
right, and the problem is if the oncologist is not partnered with someone like me who's actually has a doctoral degree in the pharmacokinetics and the pharmacognosy of how these things interact,
Mhm.
then they are just telling their patients don't take anything, or they've read a study and they're saying take B6 or do this or do that without really understanding how those natural therapies partner with the drugs or the immunotherapy that they're giving. And
Sure.
immunotherapy, as it skyrockets, new drugs
Yep.
come out every month, the oncologist is you can barely keep up with genomics and immunotherapy, much less also have to become a doctoral candidate in natural medicine, and
Right.
so
Right.
I think that gap, the idea that the oncologist needs to be educated in natural medicine and can be educated in natural medicine, and the patient really desiring natural medicine means that there's so much potential for mistakes and abuse. And that's a problem, a huge problem. Like I have seen patients come in who have seen a vet, a large animal vet for care. I have,
What?
I've had a 19-year-old come in with a 2-year-old with a fatal cancer who CPS was called and she wasn't allowed to be with her child when she was dying because she refused pediatric nutrition and wanted to give the baby something called angel milk that she had gotten from an herbalist. I've seen MDs who are in the functional medicine space who charge ten to $15,000 for IV therapies, and a breast cancer patient having a tumor that's about to break out of the chest wall and has not seen oncology. So I can't tell you because
That's
I'm
malpractice.
in this. Yeah,
Yeah.
I can't tell you how I'm in this side of the field, and how many patients I'm seeing who come to us who are, they're very vulnerable. There's no licensing around the term natural, holistic, integrative. It means nothing in the state of Michigan or in the state of New York. There are no board certified integrative oncologists in the state of New York. There's only 3 in Michigan. If they find us, it's by, pure luck, or their oncologist is just, good at knowing
Wow.
what to do.
Sure.
And they're coming to us sometimes a list of 20 supplements that they're taking. Even green tea can interfere with the efficacy of Taxols or taxanes, which is a group of cancer drugs that are used
Mhm.
widely in
Sure.
breast cancer, for example, or tamoxifen, which is, as Tiffany and I were just talking about, one of the estrogen blockers
Sure.
that's given in survivorship. And green tea can interfere at over 2 cups a day, and yet
Wow.
it's
Yep.
considered benign. And
Right.
so it's really, I think it's really, really tough for a person who's diagnosed to know, what do I do?
Yeah.
And then you get on
Sure.
the internet and there's this truth about cancer series, or there's all these talking heads that are telling you the system is meant to take advantage of you. Pharmaceutical companies don't care about you as a person.
Right.
The oncologist is making
We're
money off.
hiding the secret. Wewe're hiding the secret cure.
Yes, there's a secret for cure, and we're hiding that.
We're hiding
And
it for the pharmaceutical
and the
companies, right?
yeah, and the oncologist is at a disadvantage because they don't have that personal presence or the website or the whatever. The
Right.
patient's coming in and they automatically feel they're automatically in opposition to their care. And that's, I
Yeah.
think, where supportive care is so essential because it's necessary, but it's both dangerous to use it without, the knowledge to do so,
Mhm.
and it is also dangerous to not use it. And
Wow.
therein lies the dilemma,
You
you
know,
know?
you and I need to have further conversation on this. This is absolutely fascinating. And I have to say, if you haven't thought about it already, once you decide to take a step back from patient care on a regular basis, you need to create a course. You need to create a course
So,
on this.
it's funny that you say that. So, I did Tony Robbins' 3-day course a long time ago. And in that course, he really talks about like finding your pain points. And one of my pain points is the cost of care. So my goal and my dream would be to see every comprehensive cancer center have someone like me or
Mhm.
a group of people like me on staff. Um, and but until then, I'm in the private pay space,
Sure.
and it is very, very expensive. And so I always really struggled with how do I reach more people, especially people who can't afford to see me. And so
Mhm.
I did decide to do a video series and a book
Oh,
that
great.
will help a newly diagnosed breast cancer patient because, and I want it to be as narrow as possible, um, kind of navigate this diagnosis without prescribing or treating that patient. Um, Without me prescribing to or treating that patient. And so I've been working on that now for 2 years. I'm
Nice.
hoping to be done this year, but life always gets in the way. Practice
Did
gets
you
in the
oh,
way.
singing to the choir on that one. Did you start your video series yet?
So I have like 40 chapters, but it starts with so I'm diagnosed with breast cancer. Now what? Like where do I go now? And I don't know, can you still see me?
Yes, I do.
Oh, good. I was gonna read out like or say some of the chapters just so you can get a
Sure.
sense of.
Let me just tell
So cost of care. Um, how do we approach cancer holistically? What about supplements? Demystifying your scans. Who do I need on my cancer team? Who's my support team? Myths and truths about surgery. Protecting your lymphatic system. Preparing for surgery. Um, I've been told that I need chemotherapy. How do I understand my drugs? Botanicals and breast care. What do
interesting.
I do about the environment? So there's a lot of pieces that I think can be answered in this, and I'm hoping to finish. We'll see how we'll see how well I do.
That's wonderful, really. Very excited to read it. Hopefully, you and I can trade books and help complement because,
And
it's
collaborate.
interesting.
Yeah.
And, my book covers a lot of those things also, but I would bet that you and I discuss them very differently, which is very interesting and
That's
both important
interesting.
and
Yeah.
both useful, but I bet that we come at them differently. So it would be very
That
interesting for
is
us to
so
share and
interesting.
collaborate, right?
Yeah, yeah, totally. I think you're probably very right. Um, yeah.
And need I'm not saying one's better or worse, right or wrong,
No.
or I'm just saying that I bet if we took comparable chapters, that they would complement each other in a lot
Yeah,
of ways.
I
I
bet
think
you're
that's
right.
really
I bet you're right. Yeah, I mean, for example, when I'm talking about surgery, I talk a lot about what do your breasts mean to you. How do you identify yourself as, um, are you a person who for whom beauty is important, is
Hmm.
that a big part of your identity as a woman? So there's a lot of psychological pieces. And I have
Sure.
trained a lot in clinical psychology, clinical nutrition. So that's
Sure.
a big piece of what we do.
Fascinating. Well, to be continued.
Yeah.
Sheba, this was absolutely one of my favorite conversations. I've learned so much. I love your approach. I think you bring so much to the world of oncology, and we just need more people like you. So maybe we can clone you soon. Um,
You know what I realized, Tiffany? I realized that on that bottom left, when I'm identifying myself, for some reason it says test, and I forgot to put in my
I know,
name and
I know.
where I am, and how disappointing. But to reach
I
us,
So what I will do is I will try and have that stuff cut out. I'll cut mine out also. So or because I didn't tell you to put your name in. Um, so what I will do at the end, I have to make a little bit more of a summary station statement now, but what I'll do at the end is put up a tile, like a thumbprint with contact information for us.
perfect, perfect.
So let me just ask you now about that, and then we'll cut that stuff out. Um, so Sheba, how can people reach you besides me? Not to mention the fact I need your cell phone. I mean, personally, I couldn't I wanted to get in touch with you last night, but email it is. But I need your cell phone. But how do you want everybody else to get in touch with you? How can we learn more about what you do, become a patient, read your blog, what have you?
So you can go to AIM, AIM, like
Hmm.
Associates of Integrative Medicine, aimnatural.com, and click on the Contact Us page. And all my patients have my cell phone. But the office line is 248-798-2942. We see patients over telehealth if there are other places in the world, and if they're in Michigan, we see them in person. It's ideal to see patients in person, but of course, we can consult over Zoom if we have to. And to become a patient, you really just need to get on the website, which again is aimnatural.com, and read a little bit about what we do, get a sense of if we're the right fit for you. And when you call or email us or contact us, a fellow from my practice, which is a doctor who's finishing their training in what we do, will call you and spend some time with you on the phone. So 20 to 40 minutes talking about what you're facing and making decisions with you about whether we're the right fit for you.
Wonderful.
Once you decide to join our practice, we'll do some counseling on genomics, on finances, and then get you started.
Can you give me that phone number to your office one more time?
Yeah, it's 248
Mhm,
798
mhm.
2942.
Perfect.
Mhm.
So I'm running it
Awesome.
now across the bottom, but this will also be all in the show notes so that everybody can get in touch with Dr. Roy. I thank you from the bottom of my heart from taking all of this time. We've had a very, very interesting conversation. I've learned so much from you, and I really, really appreciate what you do for the patients. And I really hope that we can collaborate and work more together. And I'm definitely going to have you back on the show. Sounds great?
It was definitely my pleasure, Tiffany, and same to you. I think, imagine what the world for cancer patients would be like if we were all collaborating in this way and really
Yeah,
had the heart that you have to empower patients. I think
thank
um,
you.
cancer can be transformative. It can be a conversation between you and your creator, or whatever you believe in. For,
Mm,
as I said in the beginning, why am I here? What is my purpose? And
yeah,
so it's beautiful to see you moving patients towards that.
thank you.
Yeah.
So I bid you goodbye, everyone, and on to our next stream, and hopefully we'll see you all soon. Bye bye.
Bye bye.